Everyone. We might still have a few people slowly joining us, and that is okay. So just to note, we're going to get started, but just to note that if you have any questions during the presentation, please use the chat box or the Q&A box. And please note that video and audio is not available for participants during the Zoom meeting. However, you can ask to be unmuted if you wish during the Q&A portion at the end. And we will also be recording this webinar for use on our RNAO website. So good afternoon, everyone. My name is Amy Burt, and I'm the lead guideline development methodologist of the Vascular Access BPG here at the Registered Nurses Association of Ontario. Thank you so much for joining us today, and I would like to welcome you to this first webinar of our 2-webinar series, as we introduce one of our newest best practice guidelines, Vascular Access 2nd edition, which was published this past June. Today's webinar will be presented by some of those involved in developing this guideline, including co-chairs of the guideline, Dr. Nancy Moreau, CEO of PIC Excellence, and Darlene Murray, Interprofessional Education Specialist at the Hospital for Sick Children. Presenters also include myself and guideline development methodologist Christine Buchanan. The objectives of today's webinar are to describe the purpose and scope of the guideline, to describe a little bit about the guideline development process, as well as to highlight guideline recommendations and some practical implications. Before we begin, we thought we'd give a bit of background on RNAO. RNAO is the professional organization representing registered nurses, nurse practitioners, and nursing students in Ontario. We are the strong, credible voice that leads the nursing profession to influence and promote healthy public policy and clinical excellence. A signature program of RNAO is the International Affairs and Best Practices Guideline, IABPG Center, which houses the Best Practice Guideline Program. RNAO's BPGs are actively implemented across Canada as well as internationally through partnerships with our Best Practice Spotlight organizations, or BPSOs. The Health Policy Program is another core pillar of RNAO as well. The RNAO BPG program was launched in 1999, and it's funded by the Government of Ontario. The purpose is to develop, disseminate, and actively support the uptake and sustainability of evidence-based clinical, healthy work environment and system BPGs, to evaluate their impact on patient, organizational, and health system outcomes. We currently have 49 BPGs, though this number continues to grow, and a variety of implementation toolkits to support the implementation process. As mentioned, a signature program of the RNAO is the Best Practice Guideline Program, which includes 3 integrated pillars of guideline development, guideline implementation and sustainability, and guideline monitoring and evaluation. These pillars inform one another and work in sync to improve outcomes for persons receiving care, providers and organizations and systems. During this webinar, we will mostly be focusing on the pillar of guideline development. In webinar 2 of this series, we will focus on the implementation and evaluation pillars. The Vascular Access 2nd edition Best Practice Guideline has been published this past summer, and you can download the full guideline for free on the RNAO website. We can also put a link in the chat box for you. And now I'm going to pass it over to our co-chair, Nancy.
Welcome, everyone, and thank you, Amy. But before we move forward, I'd like to take a moment to acknowledge all the amazing people that contributed to the development of the Vascular Access Best Practice Guideline and recommendations. These people made it all happen. As you can see here, it took a large team of individuals to organize, review, and facilitate the expert panel with guideline and recommendations. We owe them much appreciation for their excellent management and patience in completing the process, even during a pandemic. So thank you all. We also want to acknowledge the tremendous expertise and guidance of the expert panel for these guideline recommendations. The expert panel provided critical and valuable oversight and support in the development process. The expert panel consisted of registered nurses, nurse practitioners, and registered practical nurses from a variety of sectors and settings, as well as interprofessional representation. This was an excellent group of individuals who spent approximately 18 months or so contributing to the development of this guideline. So thank you so much to all of the members of this expert panel. In addition, we want to thank the 78 stakeholders that reviewed the guideline, who represented a number of diverse roles, clinical settings, and geographical areas. So thank you all for your contributions to creating what we think is an excellent set of guideline and recommendations. In the next few slides, I'd like to provide for you a high-level overview of these best practice guidelines specific to the purpose and scope, the main recommendation areas and methodologies that we use to develop this guideline. The main purpose of this guideline is to provide nurses, including nurse practitioners, registered nurses, registered practical nurses, and nursing students, and the interprofessional team with an evidence-based recommendations and resources related to the insertion, assessment, and maintenance of vascular access devices for the adult, the infant, and pediatric populations. When we think in terms of guideline scope, this best practice guideline applies best to all practice settings where patients with vascular access devices are cared for. Those may include the primary care setting, long-term care settings, acute care, and community care. All healthcare providers who insert, assess, and maintain vascular access devices are included in the scope of this guideline. It also includes all domains of nursing, which would be clinical, practice, research, education, and administration. And I hope each of you can recognize that your area of specialty that these guidelines would apply to. So now it's time for me to look over the recommendation areas that we prioritized by the expert panel. For each of the guidelines, there is one good practice statement and 6 recommendations. And I think I skipped a slide, so apologies. When we look at the topic areas that the guideline does cover, they include pulmonary arterial catheters, implanted subcutaneous ports, intra-articular devices, large bore introducer sheaths. So just to clarify, these are areas that are not included in the guideline. So the arterial catheters, the implanted pumps, the intra-articular devices, large bore introducer sheaths, arteriovenous fistulas, the hemodialysis catheters, subcutaneous catheters, epidurals, intrathecals, intraosseal. Each of these specialized vascular access devices are considered outside the scope of these particular guidelines. And so now on to the recommendations that were prioritized by the expert panel. Each of these guidelines have one good practice statement and 6 recommendations. The good practice statements focus on completion of a systematic assessment. The 6 recommendation areas are specific to education, vascular access specialists, blood draws, a daily review of peripheral vascular access devices, visualization technologies, and pain management. And we'll discuss each of these in more detail in the coming slides. So now it's time for me to pass it on to Christine to talk to us a bit more about the methodology used with the development of this guideline.
Thank you, Nancy. This RNAO best practice guideline was developed using GRADE methodology, and GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation, and is used for quantitative studies. The RNAO implemented GRADE because it is in line with international guideline development standards, and it is being used by other large organizations that produce guidelines, such as the World Health Organization and National Institute of Health and Care Excellence, also known as NICE. So based on GRADE, there were two strategies used to inform the development of recommendation statements within this best practice guideline. The first is systematic reviews. We conducted systematic reviews on the 6 priority recommendation areas noted on the previous slide by Nancy. So education, vascular access specialists, blood draws, a daily review of PVADs, visualization technologies, and pain management. To conduct the systematic review process, our RNAO BPG team works with a health science librarian to run the searches in multiple databases. 2 guideline development methodologists simultaneously screen thousands of articles and include relevant studies. Then we appraise the quality of the included studies and complete an evidence synthesis and develop summary documents, which include recommendation statements. These summary documents and recommendation statements are presented to the expert panel, and they vote to determine if they agree or disagree with the recommendation statements, as well as vote on the final strength of the recommendations. In addition to systematic reviews, we also developed one good practice statement for this guideline, a systematic assessment prior to inserting a vascular access device. In GRADE guidelines, a good practice statement refers to a practice that is already accepted as beneficial or practical advice. A systematic review is not required to develop good practice statements. When developing the good practice statements, we include GRADE literature as well as peer-reviewed studies to support the discussion of evidence. So what you can see on this slide is a Prisma flowchart that indicates the rigorous process for the systematic reviews that the RNAO guideline team conducted for each of the recommendation questions. Our systematic reviews were aided with the help of a health science librarian, and the original searches were conducted in 2018 and then updated at the end of 2020. We asked 7 research questions and screened over 65,000 articles. Of these, almost 900 full texts were examined for relevance, and finally, 174 articles were included to inform the 9 recommendations in this BPG. The GRADE methodology provides a framework for the systematic reviews, including specifying healthcare questions, choosing outcomes of priority and importance to people, evaluating the available evidence, and bringing together the evidence with considerations of values and preferences of persons, clinical expertise of clinicians, researchers, and educators to arrive at the recommendations. Each of the included studies was also quality appraised using the appropriate and validated quality appraisal tools. You'll notice that within the guideline, beside each recommendation statement, there is an associated strength, either strong or conditional. What you can see on this slide are the considerations or criteria that the panel used to determine if a recommendation should be strong or conditional. In order for a recommendation to be strong, the benefits would need to outweigh the harms of a recommended practice, or the harms would outweigh the benefit of a practice that is not recommended. Most persons would benefit from the recommended practice, and there would be high quality evidence. Strong recommendations usually indicate that there is high quality evidence. However, there are 5 special situations where there may be low quality evidence and a strong recommendation is still warranted. For example, if there is potential for catastrophic harm, if it is a life-threatening situation, if there are certain harms, or if one option is clearly more costly or risky than the other. For a conditional recommendation, the benefits probably outweigh the harms of a recommended practice. However, perhaps not everyone will benefit from the practice, or there is low quality evidence or more evidence needed. So next I will provide an overview of how to read components of the recommendations within the guideline and navigate this large in-depth document. For each recommendation, you will see the recommendation box as shown on the screen, which outlines the recommendation statement, the strength of the recommendation, and the certainty of the evidence of effects. The recommendation box is followed by the discussion of evidence for each recommendation. The discussion of evidence includes 6 components that I'll explain now. So the first is the benefits and harms. In simple terms, this section highlights the desirable and undesirable outcomes reported in the literature when the recommended practice was used. The second component is values and preferences, and it highlights preferences for a recommendation and the value placed on the resulting health outcomes from a person's perspective. The third component, health equity, highlights the impact the recommended practice could have on health outcomes across different populations or settings, and potential barriers to implementing the recommended practice in particular settings. The fourth component, expert panel justification of recommendation, provides rationale for expert panel's decisions regarding the strength of the recommendation. And specifically, this section details why the panel decided to vote the strength of the recommendation to be strong or conditional. Following the panel justification, you will see the fifth component called practice notes. This section includes pragmatic information on conducting the intervention. And this information can come from the evidence as well as from the expert panel. The final and sixth component of the discussion of evidence is the supporting resources. And this includes relevant resources such as websites, links, tools, etc., related to the intervention. Now I'll pass it back to our co-chairs, Nancy and Darlene, to go through the good practice statement and each of the recommendation areas in more detail.
Thank you, Christine. So now we're going to get into the contents of each recommendation and the good practice statements in a bit more detail. Next slide, please. So our first good practice statement reads, the expert panel recommends health providers complete a systematic assessment of the person prior to inserting a vascular access device. As Christine mentioned earlier, this is a good practice statement, which means it's not based on the systematic review of the evidence. Conducting an initial assessment of a person before developing a plan of care or any intervention is a standard of professional practice. As such, a systematic assessment of a person prior to having a vascular access inserted is good clinical practice. The practice notes in this area provide 4 main elements of assessment. 1, vascular assessment, which means looking at the frequency of the vascular access, duration of treatment, what prescribed therapies might be involved, and history of vascular access, just to name a few. The other consideration is the psychosocial assessment, looking at age and development, looking at anxiety, needle phobia when planning. In addition, we want to look at device selection, considering what medications will be used. Are they vesicants? And overall looking at site selection. The expert panel cautioned that this may not always be possible for all components of a systematic assessment of persons needing a vascular access, specifically in the time when there's emergency care situation. We should not delay life-saving vascular access interventions. Next slide, please. So there are 3 appendices associated with this BPG good practice statement on assessment. First is Appendix F, which provides an overview of the different types of vascular access devices available. Appendix G includes the UK's Vessel Health Preservation Framework. This detailed evidence-based framework includes a right line decision tool to assist in device selection, as well as details of performing a peripheral vein assessment. Appendix H provides a list of vesicant medications. Next slide, please. So moving on, we're now looking at recommendation 1.1, which reads, the expert panel recommends that the health provider provide comprehensive health teaching to persons and their family or caregivers about their vascular access device. Comprehensive health teaching involves a combination of learning experience designed to help improve knowledge and skill related to self-management in the person and their families, or caregivers. The evidence was focused on comprehensive health teaching in the CVAD care setting. Although this literature was on CVADs, the expert panel felt that health teaching in all vascular access would be beneficial, and it determined that it should be inclusive of all vascular access devices. The studies that we did look at, 2 studies focused on self-management education, while 7 studies focused on family or caregiver education, with the majority of these focusing on parents or caregivers providing care for children. The evidence suggests that comprehensive health teaching may reduce complications and hospital readmission rates. However, based on grade, the evidence is very uncertain. Some key practice notes to include: the amount of and formalization of health teaching may be dependent on the type of vascular access device and the overall discharge plan. When you're, for an example, a peripheral IV that's going to be inserted during a hospitalization and removed before, that teaching may not have to be as in detailed, but a person going home with a central venous access device may require something a little bit more comprehensive. At a minimum, when we are teaching, the teaching should include signs and symptoms of complications. This should also include details about where, how, and with whom to follow up and seek assistance if complications arise when discharged home with a vascular access device. Next slide, please. Okay, thank you. In addition, the practice notes state that a comprehensive health teaching should follow a teaching plan or a checklist. Appendix I provides an example of a PIC teaching guide. I'm now going to pass it over to Nancy, who's going to tell us all about recommendation 2.1 and 3.1.
Thank you, Darlene. And now for recommendation 2.1. In recommendation 2.1, the expert panel recommends that health service organizations implement practical education on the insertion and/or management of vascular access devices for health providers. For the purposes of this best practice guideline, practical education refers specifically to skills practice to supervised insertion and management of vascular access devices, hands-on training, or one-on-one training for health providers. This education and training may also include high-fidelity simulation training. Evidence suggests that practical education for health providers improves the number of successful insertion attempts, likely reduces complications in persons with vascular access devices, and may improve provider attitude and confidence with insertion-related complications. Although evidence is low for this outcome, the expert panel did have a recommendation that was strong. Some key practice areas and notes from the expert panel included the preference for high fidelity simulation be used for complex cases and skills, that they recognize that high fidelity simulation may not be feasible in all practice settings due to factors such as cost or accessibility. And then the recommendation notes also include the recognition that health providers may have a loss of skill over time, that each may require refresher, ongoing, and consistent education to be offered to the healthcare providers. Within this recommendation 2.1, there are related appendices. Each of these guidelines have expanded information, often provided in a practical form for best application in the appendices. The additional practice notes for this recommendation state that education should be standardized within the health service organization with identification of specific educational competencies as outlined within a plan or policy. In Appendix J, you see an example of the global rating scale that can be used for evaluating ultrasound-guided peripheral vascular access device inserters. Now on to recommendation 3.1. In recommendation 3.1, the expert panel recommends that acute care health service organizations integrate vascular access specialists or vascular access specialist teams to support the insertion and management of vascular access devices. A vascular access specialist team refers to a group of health providers who have attained advanced knowledge and skills in the assessment, insertion, care, and management of vascular access devices. These teams include intravenous therapy teams, individual vascular access specialists that may be interdisciplinary and may include nurses, physicians, respiratory therapists, laboratory technicians, radiological technologists, and physician's assistants, nurse practitioners. All of these may be part of any specialist team. Evidence suggests that the implementation of vascular access specialists and teams may reduce all vascular access complications, and that it will likely also improve first-time success, reducing the number of insertion attempts necessary to establish a vascular access device. 5 of the studies reviewed focused on the insertion and management of central venous access devices, including peripherally inserted central catheters, while 3 of the studies focused on the insertion and management of peripheral vascular access devices. All of these studies took place in an acute care setting, making this recommendation specific to acute care. The lack of studies for alternate care sites was considered a research gap for this recommendation, and thus the expert panel recommendation was conditional because it did not apply to all areas of practice. With that in mind, the expert panel still felt there were likely benefits to having specialists and teams in other practice areas, such as long-term care or in-home care. Within this recommendation, the key practice points included were organizational provision of training, consideration for certification, additional policies and responsibilities that should be outlined for the specialist or team within each individual health service organization, as based on their resources, patient acuity level, and overall population needs. Additional details on implementation and organization of vascular access specialist teams can be found within the practice notes, with some additional reading also noted in the supporting resources. This concludes recommendation 3.1, so I'll now pass it back to Darlene to tell us about the next 2 recommendations.
Thank you, Nancy. We are now on to recommendation 4.1, which reads, the expert panel suggests that health providers perform venipuncture when drawing blood samples to maintain specimen integrity. The evidence suggests that venipuncture for drawing blood samples may reduce specimen rejection and may reduce contamination of blood cultures compared when drawing from a vascular access device. However, one study also suggested that venipuncture for drawing blood samples may reduce patient satisfaction when comparing drawing of blood from a vascular access device. The certainty of the evidence was very low. The expert panel cautioned that with any blood draws, health providers must adhere to a standardized blood sampling protocol or organizational policy. Additionally, the expert panel cautioned if venipuncture is not feasible following an individual risk-benefit assessment, then a blood draw from a vascular access device may be considered. The individual risk-benefit assessment should include personal factors such as age, the pain and management of comfort, also looking at whether the patient has difficult venous access or a history of difficult venous access. Other things to consider is the vascular access device factors, such as the size and location, and what is the current infusion therapy. And blood sampling factors include such as the need for accurate blood sampling and frequencies of blood draws. Other key practice notes to be included would that venipunctures are to follow current best practice, such as including aseptic technique and appropriate vein selection. We also recognize that health providers need adequate training and education on blood draws and vascular access to support this recommendation rather. Next slide, please. Recommendation 5.1 reads the expert panel recommends that acute care health service organizations implement a multi-component peripheral vascular access device or PVAD care protocol. A multi-component care protocol is a group of evidence-based intervention that can ensure a delivery of standardized method of care. Many of you may be more familiar with this as a care bundle. The multi-component care protocol involving a PVAD daily review and documentation, and at least one of the following interventions: hand hygiene, aseptic care and technique, provider education and training, person and family caregiver involvement, standardized PVAD equipment, standardized securement device, and inclusion of a PVAD assessment at rounds and handover. Also, the majority of studies also included the assessment of device necessity as part of this daily review. These daily reviews should be completed by health providers in collaboration with persons and their family. The evidence suggests that multi-component PVAD care protocols may reduce complications. All these studies did take place in acute care setting. Therefore, the recommendation is specific to acute care, but the panel also felt that it could be some overlap into other areas of care as well. Key practice notes include PVAD care is just not the responsibility of the individual provider. It also needs to be incorporated into health organizational policies and procedures. In addition, the practice note states that assessment of a PVAD needs to follow an established protocol. On your screen, you will see Appendix L, which provides an example of a PVAD assessment protocol. In addition, you will find in Appendix G, the UK Vessel Health Preservation Framework, which includes some details that might be helpful in a daily assessment. Next, let's move over to Nancy, who's going to walk us through recommendations 6.1 and 6.2.
Welcome back. Let's talk about recommendations 6.1 and 6.2. Within these recommendations, we're going to speak specifically to the use of visualization technology and ultrasound guidance used during the insertion of a peripheral vascular or arterial access device. In recommendation 6.1, the expert panel recommends that health providers use ultrasound guided technique for the insertion of peripheral arterial catheters. The evidence suggests that the use of ultrasound guided insertion technique for the insertion of peripheral arterial catheters increases the first attempt insertion success of these catheters and thus likely reduces complications. The expert panel determined this recommendation to be strong based on the moderate quality evidence, which clearly demonstrated benefits and decreased harm by the use of ultrasound during peripheral arterial catheter insertion. In recommendation 6.2, the expert panel suggests that health providers use ultrasound guided insertion technique for the insertion of peripheral vascular access devices for persons with known difficult intravenous access. Evidence suggests that the use of ultrasound guided techniques for the insertion of peripheral catheters in persons with difficult intravenous access may increase the first attempt insertion success and decrease complications, and that it will likely increase patient satisfaction. However, the certainty of the evidence according to the grade criteria was very low. And so you can see that the recommendation was conditional. A validated scale can be used to determine a person's status as a difficult intravenous access patient or DIVA. The DIVA status should be assessed by an expert in peripheral catheter insertion or a health provider who's appropriately trained to use the validated DIVA scale as demonstrated in the Van Loon studies. The expert panel determined that this recommendation could be conditional due to the very low certainty of the evidence in this area, as I already mentioned. Additionally, the expert panel felt that the success of this recommendation would be dependent on individual characteristics of the healthcare provider and of the patient receiving the peripheral vascular access device, the training and the expertise of the health provider, and the availability of ultrasound at the practice site. For both of these recommendations, the expert panel cautioned that appropriate scope of practice and level of training or expertise needs to be considered when applying the recommendations and determining the most appropriate health provider to insert the device. This recommendation will have to be implemented with more care and thought to the persons receiving care, the providers using ultrasound-guided insertion techniques, as well as within the clinical setting itself. The key practice notes for these recommendations of 6.1 and 6.2 are that training on the use of ultrasound needs to include a basic understanding of ultrasound technology, as well as the ongoing maintenance of competencies specific to the insertion techniques and needle guidance. That it also should include training of healthcare providers in ultrasound-guided techniques specific to practical education with that technology. That inserters using ultrasound guidance should also be evaluated periodically based on insertional success and outcomes. For the related appendices for these recommendations, there are two. These two ultrasound guidance recommendations include Appendix K and Appendix N. Appendix K provides an example and a diagram of what an ultrasound guided device technique might look like with the needle advancement using the ultrasound transducer. Appendix N provides an overview of two validated difficult intravenous access scales, one specific to adults and one for children. And I now pass the gavel back to Darlene.
See, we're heading down the home stretch here with our recommendations. Now we're on to recommendation 7.1 and 7.2, which speak to pain management during the insertion of a vascular access device. Recommendation 1 reads, the expert panel recommends that health providers offer adults non-pharmacological and pharmacological pain management strategies during the insertion of a vascular access device. The evidence suggests that both pharmacological and non-pharmacological pain management interventions probably will decrease pain, fear, and anxiety related to the procedure, and it will increase patient satisfaction and comfort during the insertion of the vascular access for the adult population. Recommendation 7.2, the expert panel recommends that health providers offer non-pharmacological and pharmacological pain strategies during the insertion of a vascular access device to infants and children tailored to their age and developmental stage. Evidence suggests that both pharmacological and non-pharmacological pain management interventions may decrease, again, pain, fear, and anxiety, and increase comfort. And you will probably see an increase in patient and parent or caregiver satisfaction during the insertion of that vascular access device for the pediatric population. Various types of pharmacological interventions were used in this study, including fentanyl prior to a CVAD insertion, or needle-free power and lidocaine delivery system that could be given prior to venipuncture or peripheral vascular access insertion. Unfortunately, this system is not available in Canada. and a use of topical anesthetics such as lidocaine cream, as well as medications such as acetaminophen, ibuprofen, or melatonin prior to PVAD insertions in children. Non-pharmacological interventions included both physical and psychological interventions, such as distraction techniques, acupuncture, acupressure rather, a vibrating cold device, a vapor cooling spray, crushed ice, heat applications, aromatherapy, and a virtual reality device or hypnosis. In addition, there was interventions seen such as breastfeeding or comfort hold or positioning for infants and children. Some key practice notes include aseptic technique needs to be maintained during a vascular access device insertion, regardless of the type of pain management strategy used. Decision around the pharmacological pain management interventions may require an individual risk-benefit assessment, including but not limited to factors such as person and family preference, whether there's presence of needle phobia, fear, anxiety about the procedure, the DIVA score, which Nancy had mentioned earlier, or a history of difficult venous access. We also want to consider the type of pharmacological intervention and potential side effects, such as vasoconstriction associated with some topical medications. Additionally, for recommendation 7.2, pain management strategies should be appropriate to the various ages and stages should be considered. In Appendix O, you will see a detailed, a wide variety of pharmacological and non-pharmacological options for pain management across the ages and stages for the pediatric patients, including infants, toddlers, and young children, school-age children, and adolescents. Next, we'll get Amy to walk us through some of the wrap-up slides. Thank you.
Thanks so much, Nancy and Darlene, for walking us through all the recommendations. So one additional appendix that we wanted to point out to all of you is Appendix P, which provides a recommendation workflow algorithm. You can find it on page 153. And this workflow is for nurses and other health providers to follow so they can see the relationship between recommendations to one another. And just an overview of all the appendices and are listed here. So we definitely recommend that you have a look through them as well, along with the recommendation areas, as there's lots of useful information hiding in the appendices. Additional content in the guideline includes evaluation and monitoring measures on page 16. If you're an organization implementing this best practice guideline and you want to know the impact of the recommendations on practice change or on person outcomes, you can use the measures outlined in these charts to monitor implementation success or areas that may require further change initiatives. These measures were developed with the panel and also received internal and external feedback. For more information, though, on evaluation, please join us next week for our next webinar on implementation and evaluation, which is going to be same bat time, same bat channel, November 29th from 1 to 2. To further support implementation of this guideline, first and foremost, we encourage you to download and read the guideline and perhaps discuss it with some of your colleagues. You can also take a more structured approach by conducting a gap analysis as an interprofessional group. The gap analysis will allow you to compare current practice to evidence-based practices in the guideline. You can also become a best practice champion by joining one of our free Best Practice Champions virtual workshops that highlights why evidence-based practice is important and how you can champion best practice in your organization. And if you'd like to take it one step further, we encourage you to consider applying for your organization to become a Best Practice Spotlight Organization, or BPSO, which enables organizations to go into formal partnership with RNAO to implement clinical guidelines within the organization and receive a designation. And each of these steps, including some more implementation considerations, will be discussed at our webinar next week. We'd also like this opportunity to introduce you to the Leading Change Toolkit, which is our newest implementation toolkit, which was just launched this fall. It's a free, dynamic, practical online resource for creating change within health service organizations. The goals of the Leading Change Toolkit are to promote healthcare excellence at the point of care and to create sustainable, evidence-informed cultures. It includes 2 complementary frameworks that accelerate success in the uptake and sustainability of knowledge. So there's the Knowledge to Action framework, which is also found in the 2nd edition of the toolkit. Some of you might be familiar with it. And then the new Social Movement Action framework. And again, this toolkit can be found online, and we'll also be discussing the Leading Change Toolkit further in next week's webinar. If you have any questions regarding the guideline that we don't get to cover today, or about implementation or evaluation of the guideline, please feel free to contact myself via email on the screen, or you can also contact us through the general contact us on the RNAO website. So we're now going to have the opportunity to hear from you. If there are any questions or comments, and we're also wondering if any of you would like to share what some of your reflections about the details of this best practice guideline are, or perhaps if any recommendations really resonate with you and you would like to see them implemented in your organization. So we've got, I think, about 15 minutes, just maybe a little less than 15 minutes to answer some questions or comments. So feel free to type questions in the chat or use the Q&A, or if anyone would like to share a little bit more in terms of a comment or maybe an example from their organization, you can ask to unmute and speak with the group.
Well, and thank you, Amy. I'd like to add also, as you think about these recommendations, how can you apply them? What makes them potentially significant for your care setting? And how might you utilize them? Does it have any value for you? I mean, those are the types of comments that we would love to see and hear some feedback from you all, and help to validate some of the years of work that we've already put into these recommendations and the guidelines specifically.
I see one question here. So the question is, what are the recommendations for vascular access knowledge acquisition prior to skills application? I see the guideline recommending standardized skill assessment.
Yeah, so I guess if I can start this out and then pass it to Darlene. We all deal with intravenous devices in our care settings as nurses, and being able to have an adequate level of skill to be able to insert peripheral catheters and potentially peripherally inserted central catheters or midlines, it is certainly something that we must consider as far as what the skill requirements would be. There are competency lists that are available. I know as an educator myself, I have a number of competency assessment tools that can be used in order to guide educational processes from both a practical as well as potentially online course-driven educational processes. But if we're talking about specific skills, what do they need? Well, with peripheral catheters, they need to know what type of catheters are available, what the components are of the catheter, from very basic level, and then the tips that they can use in order to successfully insert that peripheral catheter. And then you add on the potential for ultrasound guided needle insertion, and there would be additional skills that would be necessary in order to understand ultrasound and how to guide that catheter into the vein. Darlene, do you have some things to add to that?
No, I think you touched on it nicely, Nancy. I think of actually our good practice statement and that component of doing that in-depth assessment prior to going in, but also as an educator is developing that competency-based program to ensure skills are met and also maintained. So you have to also look at that skill from the point of view, are you going to be able to continue applying this skill? To learn it once is never enough. It is something you're going to have to continue throughout your practice in order to maintain that specific level of competency, whether that is peripheral IV insertion, central line PIC insertion, or ultrasound guided. It's something you have to sort of be embedded in to sort of maintain everything.
Well, and that brings up the point also that we need to have some sort of outcome management. Nobody wants to admit that they're not good at something, or that, you know, it just doesn't come naturally. And so helping each other, going in for insertions with two clinicians can be helpful, but also monitoring our documentation to see how many attempts clinicians have been taking. That's part of a gap analysis to identify educational needs. Everybody's not good at peripheral catheter insertion. And so we need to help each other, and we need to monitor the level of success, and also give opportunities for clinicians to either go or receive additional education, or also to be able to shadow others who are really good at it. I know in my hospital, when I worked on a vascular access team, we invited the floor nurses to come and shadow and perform insertions with our coaching, and they often took us up on that opportunity.
I do agree with you, Nancy. We just recently have created a dashboard to look at our own indicators related to vascular access and what we're maintaining throughout the organization. And as you say, inviting people back. We actually have an elective program for some of our residents so they can come and spend time with the team as necessary. So being open to support learners.
Amy, do you want to address the other questions, or do you want us to jump in and just answer them?
Sounds good. Sorry, I've got two things open. So yeah, maybe we can do the chemotherapy clinic question. So the question here is, I work in a chemotherapy clinic. We infuse a lot of vesicants. We have some oncologists who are reluctant to order PICs and ports for patients with poor access. Clots and infection potential are what the oncologists are worried about. Did you find any references discussing the benefits on quality of life and patient satisfaction of having a vascular access device inserted?
Darlene, do you want to start on that one?
Sure, Nancy. When I think of this, this is something that I want to strive for my own organization. But when I really took a look at the UK framework and in regards to vessel health preservation, and looking at articles such as Magic out of the Michigan State University, I think I got that correct, Nancy. I think there needs to be maybe more awareness about these tools that are out there for those outside of vascular access, to understand about patient preference and family and patient-centered care in regards to what's best for them and what's going to limit the harm or the poor outcomes related to perhaps a peripheral vascular access device and the associated harm that can be associated with that. Nancy, do you want to add more? Because I know you're intimately involved with that framework, those frameworks actually.
Yeah, the MAGIC guidelines, the Michigan appropriateness guidelines for intravascular catheters, or MAGIC, has a number of resources that are on improvepic.org. There is an algorithm that's associated with it. Magic is a great tool, I think, to use with physicians to help to guide them towards the most appropriate device. When you ask about references that are discussing the quality of life and patient satisfaction, honestly, there's not a lot there. There are a few things. Dr. Marie Cook out of Australia has published a number of qualitative research reviews that had patient involvement and commentary about their value of life with different types of access devices. And there's not a lot, and we would love to have more evidence to use. And let me challenge you to be a contributor to that. These are things that we need to study in order to have more evidence to provide us with higher levels of quality to make these recommendations. I mean, you heard us talking about the recommendations and how many of them had low level research in order to support them. We need more publications, and nurses generally have not been great about contributing manuscripts and performing research. So we need to help each other in order to get some of these answers.
Thanks so much, Nancy and Darlene. So we were going to let Karen, I think, had a comment. Karen was one of our panel members. So if you want to unmute and share, Karen.
Can you hear me?
Yeah.
Yep.
Oh, great. Thanks, Nancy and Darlene. Great job on presenting the recommendations. Even though I was part of all of this, it's just so exciting to hear it like live. It's great.
We love your contributions.
Well, thanks, Nancy. My comment is, I get just in follow up to the question with regards to knowledge skills acquisition for specifically around peripheral vascular access insertion. It's a real challenge out of the hospital environment, like such as home care and long-term care, especially here in Ontario, simply because it is inconsistent how often you will see patients that require this. The other challenge has been, even pre-COVID, was trying to gain access to something like a day surgery, or we used to be able to partner with our local hospital to be able to gain that experience. However, for a whole lot of reasons, that has also gone by the wayside. So I'm really encouraging in my setting, especially, to really develop that whole simulation model and looking at creative ways of maintaining that kind of competency. So I really encourage those that are attending and hoping to implement and planning on implementing these recommendations to really seriously consider how they can best do that. And there are some really easy, economical, and creative ways, as I'm sure you can probably expand on, Nancy and Darlene, on how we can do that from a simulation perspective.
Education is everything. I mean, we have
Exactly.
to continue to have education. Like Darlene said, it's not a one-time and done.
Exactly.
My whole career has been about providing education and resource to people who were involved in vascular access. Not only for the specialists, but also for the bedside, for anyone who has any involvement with administering intravenous therapies, inserting any level of care. And I feel like that education provides some value, and sometimes just to inspire us to apply best practice, sometimes to provide us with more information. I saw that one of the comments was about using specific locking solutions in order to reduce clots. And I checked it out, and what they recommended was the EDTA, the tetrasodium edetate, edecrinic acid, I assume. So the EDTA, but you also have citrate that's available in Canada. And both of these agents can help to reduce infection, help to reduce clots within catheters, and certainly can be used for those patients who have recurrent problems. But how we know about these things is through education. And so it kind of is that link between everything. You know.
Fully agree. Fully agree.
Yeah. So I see we've got another question that deals specifically with alternate care. I think you all can see it. And so how do we provide for more information on the importance of vascular access and applying specialists within alternate care sites? It's really challenging within alternate care because maintaining individuals that have a high level of competency, that have the skills that are necessary in alternate care is challenging. But I know that within Canada, there are many pharmacies, infusion care pharmacies, that have full-time educators. I'm familiar with Daphne Broadhurst and others who have been doing this function for years in alternate care and providing really high-level education to individuals who are providing the infusion to patients. And so in many ways, you guys in Canada are better than those of us in the United States in providing that consistent education. We just have to keep at it, you know, keep pushing for the education and making sure that when patients are discharged from the hospital, that they go to a care setting or to a service that already has those skills and can validate that their clinicians have those competencies. As a legal specialist, there actually is a responsibility for acute care to make sure that their patients are going to a service that has these skills. And while we haven't really seen it exercised within litigation in the United States, the potential is there. And you guys are lucky you don't have the litigation that we have, but there is a value to litigation to help to drive better practices and drive that commitment to making sure that patients are safe when they leave acute care. Anything else you'd like to add, Darlene?
No, I think the link between acute care and the community setting is such an important one. And I know it's something that we're endeavoring on. And now within my organization, as we tackle problems, we have to look at it from the lens of the community care partners and what is feasible in that type of care setting. And how can we make sure that our messaging and the care is seamless across that? So that is something I think that is very important.
Well, and one other thing, I've seen a model that has worked really well that I use as an example, that an acute care setting that provided education and invited those alternate care providers to come to the hospital to receive the education. Very impressive. So those are some things that we might want to consider.
And I would also just add, thank you so much for the questions, Sarah, specifically about Ontario Health Teams. That's what OHT is. Nancy might not be familiar because she's down in the States, our new structure of healthcare in Ontario. We do have some best practice spotlight organizations specifically in Ontario Health Teams. So that might be a good road to have our new guidelines integrated in a more integrated way across sectors. So I'm conscious of the time. I know we are just a few minutes past 2 o'clock. If there are other questions, we can probably stay back a couple minutes to answer them, but I'll also remind you that you can always contact RNAO or myself, and that we will also be seeing you at next week's webinar. And for anyone who is not able to join next week, we will be posting both webinars online. And for any of your colleagues that weren't able to join today, we're hoping to post today's webinar before next Monday so that anyone can catch up if they need to.
Well, I don't know about you guys, but I'm really looking forward to next week because it's all about implementation. Yes, we have all these recommendations and things that we've contributed to, but most importantly is how do you get them into your organizations? How do you apply best practice guidelines? And what are some of the implementation strategies? And that's what we're going to deal with next time.
Absolutely, I couldn't agree more. I think there were a couple comments in the chat that we didn't really address today because they were more about implementation. But I think for a lot of organizations, that implementation piece poses a big challenge. Okay, so I don't see any more questions popping up and nothing else popping up in the chat. So maybe we can wrap up for today. I'm not sure if anyone has anything else to add from the panelists.
Nope. Thank you so much to Nancy and Darlene and everyone else involved today. It's been a great session.
Perfect. So thanks
you,
everyone for joining, and we'll see you next week.
See you next week. Bye.